Yep.
And you see me going back and forth?
Yes. Yep.
So reset, just my disclosure, so you see it. And let's move forward quickly to the next page. So the ALD gene basically encodes for a protein called ALDP, and ALDP is now known to be a transporter of what we call very long-chain fatty acids. So fatty acids that have more than a C22 chain length, so C24, C26, and so on. These very long-chain fatty acids are first synthesized or are part of the diet, but are also synthesized inside our cells by enzymes that are called elongases. So you see here ELOVL1, ELOVL6, and that's relevant, and we come into that in a minute. ALD protein then is transported into the is there to transport these fatty acids into peroxisomes for further degradation. And basically, the mutations in this gene result in the lack of function of this transporter and accumulation of these very long-chain fatty acids that you can then measure in the nervous system, in adrenal glands, and in testicles, and is basically a biomarker of this disease and relevant for diagnosis of this disease. This disease has different phenotypes. The most severe phenotype is, since it's an X-linked disorder, affects the boys, and it's called childhood cerebral ALD. It has its onset usually before 10 years of age. These are typically normal kids at birth that develop normally in the first few years of life. And then the clinical presentation initially is quite vague. It's some inattention, behavioral issues in school. But then once they start having actual neurological symptoms, the deterioration is incredibly rapid. And it's due to a very rapid inflammatory demyelinating disease in the brain, as you can see here. And there is a pathognomic finding of a gadolinium enhancement that characterizes it. Here you see a picture of a boy that always was highlighted by Hugo Moser himself. This is a patient of him who was, I think, 7 or 8 years old in 2nd or 3rd grade. And on the left side, you see how he was able to write in October 28th of 1983. And then just less than 3 months later, you see how his writing so rapidly deteriorated. And unfortunately, this is very much still often the case if you don't identify these kids early on. The deterioration is quite rapid once the MRI is advanced. As you can see here, this is a major functional disability scale, with 0 having no disability, and each major disability like blindness and deafness or G-tube dependence or wheelchair bound is 1 point. So you see how within a single year, how rapidly these patients are progressing and getting worse. Then there is the adult variant of this disease, which is sort of the opposite. It's a slowly progressive disease of the spinal cord, not the brain, predominantly spinal cord, which results in a spastic paraparesis and sensory ataxia due to involvement of the long tracts, the long sensory tracts in the dorsal column that go up and down the spinal cord, and the corticospinal tract that goes down the spinal cord. So it's called a long tract disease. It also involves peripheral nerves, and so it can cause a peripheral neuropathy. Very common symptoms are also bladder and sexual dysfunction. And the disease is really an axonal disorder. There is primarily involvement of the axon, and then secondary demyelination or loss of the myelin sheath. By definition, adrenomyeloneuropathy patients that we call pure AMN have basically a normal conventional MRI, but these adults are still at risk to develop cerebral demyelination in an inflammatory form that we call adult cerebral ALD, similar to the boys. So this phenotype will affect nearly all males, but also at least half of all the carriers. So if I just summarize this briefly before we get into therapies, basically males can develop these different forms of the disease, while the females predominantly develop the adrenomyeloneuropathy. Of course, what I'm not talking about at all here is the adrenal disease. That's an endocrine disorder that happens in almost all males as well. Unfortunately, there's no genotype-phenotype correlation. So one subject having one form does not mean that another relative with the same mutation will have the same form of the disease. So when we think about it, before we think about therapies, we have to think what's going on in this disease. And what we do know is that in the cells in this disease, they are at what we call a pro-inflammatory state. They are more guarded, they're more inflammatory than regular cells. We also know there's neurodegeneration, and we also know that there is endothelial dysfunction. That's been a more recent discovery by Dr. Eichler's group. And the question is, how do we get from this mutation, this very long-chain fatty acid increase to these states? And so the current working theories are that one pathway is what we call dysfunction of the mitochondria. So as a result of these accumulated very long-chain fatty acids, there is disruption of the mitochondrial function, which results in oxidative stress, which certainly can contribute to this disease state. The other thing that we can think of is the changes in the cell membrane as a result of these very long-chain fatty acids that may put the cells in a more pro-inflammatory state and also disrupt cell membrane-based signaling. In addition, there is now more evidence that there is also what we call endoplasmatic reticulum stress. So there is a cell response, as a stress response in the cells that seems to be related directly to the mutation. And that in itself can again have the effects on cell function. And more, another pathway that's been recently looked at is the so-called autophagy and mTOR regulation that seems to be increased in this disease state as well. And so there's impaired autophagy. It's dysfunctional autophagy. So these are 4 pathways that can be targeted when you try to use therapeutics. But before we get into these, what is the current standard of care? So the only standard of care right now is for childhood cerebral ALD only. The other forms of the disease don't have treatment except adrenal disease, where you can replace hormones that are missing. But this approach is basically taking somebody else's immune system and replacing the affected patient's immune system with a healthy immune system. So we do an allogeneic hematopoietic stem cell transplantation. And of course, that has a lot of side effects because you're wiping out their immune system and you're giving them somebody else's immune system. But if you do this really early on, when these boys have no neurological deficits and when they have a low MRI burden, you see that you have really great outcomes in those patients who tolerate this actual acute period of transplantation. So with about a 95% or so survival rate, especially if they are related donors, where the cells are coming from a healthy relative who's a perfect bone marrow match. So that's only for this phenotype, and of course we have all these other phenotypes that we need to target. So how do we do that? Well, the very first thing that actually happened in ALD was an idea that came from a parent, and that was to try to block the synthesis of the very long-chain fatty acids in the first place. And so by blocking this elongation process, and so what does do that? Well, there is something called Lorenz's oil, which is a combination of 2 different oils, which actually reduces in plasma very long-chain fatty acids. Unfortunately, several trials across different countries in different forms of this disease have really failed to show any beneficial effects on the degree of neurological burden or adrenal dysfunction. The only positive study is a single open label study where there was basically no controls because everybody was on the drug or was on this oil. And within that group, if you compare the ones who were really compliant versus the ones who were not compliant and were not reducing their very long-chain fatty acids, they seem to have a lower chance of developing cerebral ALD during that time period. But it's relatively weak finding. The FDA did not think that I was strong enough to approve it. And currently it's actually not available in the US, although it is available in some other countries, and we're not giving it to our patients. So what are other strategies that we can approach? So one thing that we could do is to try to turn on a gene called ABCD2. So the ALD gene is called ABCD1. And that's not working, but there is a gene called ABCD2, which has encodes a protein called ALD-related protein, which has a very similar function to the ALD protein itself and can bring in very long-chain fatty acids and bypass sort of this blockage. And there are several drugs that can turn on ABCD2 that are now being investigated. There is currently a trial by a company that is happening multinationally across the world, actually, and is coming soon, hopefully, to an end, where it's a placebo-controlled trial in adult men with adrenomyeloneuropathy that are getting a pioglitazone derivative. And then there is 2 other companies, at least that I know of, that have thyroid agonists. So the thyroid hormone ends up actually upregulating ABCD2. that are being now pursued and are going to soon start clinical trials, again, in the AMN cohorts. Since the AMN subtype has no therapy at all. So these are some exciting things that are happening as we speak. That's one avenue of approach. Another avenue of approach that, again, another company is starting to pursue is to see if we can block this endoplasmatic reticulum stress. And there is something called AMP kinase, which gets phosphorylated, and the phosphorylated AMP kinase, if it's upregulated, if it's turned on, inhibits ER stress. And so that might be another therapeutic strategy that, again, is just being pursued as we discuss. And then there's our friend Stefan Kemp, who in the 1990s was looking at a drug called 4-phenylbutyrate, which is already FDA approved. And this drug can do two things. It can upregulate ABCD2, but it can also block endoplasmatic reticulum stress. So it's really something interesting to pursue, but it has a major disadvantage. It requires really, really high doses if we want to give it in an ALD patient, based on the animal data and other human data that we have. It has a very short half-life, and it tastes terrible. And so how do we get this drug to the target so we can use a much lower dose? That's been something that we've been pursuing in our lab in collaboration with a group that makes nanoproducts called dendrimers. These are basically Christmas tree kind of structures that you can put these ornaments of drugs on top, and they seem to be very selectively delivering these drugs into the nervous system. So we have here, for instance, a picture showing that these drugs that are highlighted here in red are taken up by the green cells, which are neurons in the spinal cord of a mouse with ALD. So we've been treating ALD mice now for a long time with this drug. We have done 2 different rounds of behavioral studies, and it looks like if we treat these mice long enough with this drug on a weekly basis as an injection, their motor deficit seems to be prevented. We have done this now in 2 rounds. This is round 1, and this is round 2. So another strategy to pursue is to try to damage the oxidative stress. So antioxidants have actually been done in clinical trials. Most of them barely get into the nervous system, so that's a big challenge. And again, one avenue to pursue this is to connect it with the dendrimer, these nanotherapeutics. And so this is something called dendrimer N-acetylcysteine that is currently being pursued by a company. So you can't do any of this unless you build lots of connections, and these are rare diseases. So the only way we can do this is by finding out a standard way to collect the data across the sites, have standard protocols for clinical trials. So you have to do that by collaborating across different centers, but also collaborating with patients, collaborating with industry, and working with the FDA towards that. So I'm going to stop here with a picture of ALD Connect, which is one of the collaboratives that was put together several years ago by us to focus on ALD therapy specifically. Florian, I'm going to stop screen sharing and have Florian talk. So I'm going to stop sharing. Thank you. And Florian, if you can't, I can project your slides. Just let me know.
Okay, great. Can everybody hear me? Yes? Okay, good. Yes, so thanks, Ali. That was a beautiful introduction, and thanks for the offer to project. I'm dialing in here from Vienna in Austria, so I hope this works okay. Can you see my slides? Can you see my slides?
Yes.
Yes.
Okay, good. Yeah, so Ali actually already set the stage beautifully and gave a wonderful overview of the pathophysiology and how we think about influencing the different downstream impacts of ABCD1 dysfunction upon lipid metabolism and oxidative stress. I will here focus solely upon gene replacement in X-linked adrenoleukodystrophy, and hopefully impart how this is an evolving field that is more focused on the cell types that we're trying to correct the gene in, and that depends on the specific phenotype that we are targeting. So just to start off to say that today compared to the time that both Ali and I trained at Hopkins with Hugo Moser. The landscape has changed dramatically. We are at in a time when there are many companies interested in rare diseases, much more so than 20 years ago. And here, a picture of Boston and the industry landscape across the river. As my disclosures accordingly, I'm PI of the ex vivo lentiviral gene therapy trial sponsored by Bluebird, and I'm also founder of a gene therapy company called Swan Biotherapeutics. So while there's a lot of interest in from industry in rare diseases, I want to emphasize that we shouldn't become a boutique medicine disease. We, in the leukodystrophies, should keep our eyes out for the population at large. And that really means accounting for the many different people across race and ethnicity who are impacted by this disease. And we've, in the course of the COVID-19 crisis, really seen how disproportionately many minorities have been affected. And I will say a big worry of mine is, as some of these therapeutics roll out, that they will not be distributed evenly across the socioeconomic spectrum. So I think it's something that we need to keep in mind in medicine. So this slide really sums up the two approaches I'm going to be talking about, which is the approach to ex vivo gene therapy, which is lentivirus mediated, shown on the right. It's a cell-based approach that, in our case of ALD, is based on taking bone marrow cells, transfecting them in a dish ex vivo, so outside of the body, and then reintroducing those corrected cells into the body. On the other hand, the in vivo gene therapy approach is not based on correcting cells outside of the body, but rather delivering the gene with a virus directly into the affected compartment. And this can be into the brain directly, it can be into the liver. It all depends on where you see pathology. So here, just to summarize some of the in vivo delivery approaches to the central and peripheral nervous system. So usually when you use an AAV delivery, you can go intraparenchymal. That means injecting directly into the brain. You can inject intrathecally, which means into that space where you usually draw CSF from during a lumbar puncture, or you can give it intravenously, directly into the systemic circulation. Then, depending on what regions of the brain are affected and what the pathophysiology of the disease is, there might be other modalities that this in vivo gene therapy takes advantage of. For instance, in some lysosomal storage diseases, and there are several among the leukodystrophies, cross-correction is possible. So if you deliver it into one cell, it might be able to be corrected in neighboring cells. Yeah. So now switching to ex vivo gene therapy. As I said before, the most common form of ex vivo gene therapy for the leukodystrophies is that using bone marrow cells that we call hematopoietic stem cells. And these are transfected in a dish using commonly a lentiviral vector. And what we think happens here is that this renews a particular compartment of cells known as microglia, and they have the advantage of expressing this therapeutic protein usually for a lifetime after hematopoietic reconstitution. So this is one advantage over the in vivo gene therapy approach, that there's a continuous renewal of these cells happening from the bone marrow. So just to summarize briefly the results of the ex vivo gene therapy trial in cerebral ALD, Ali Fatemi already mentioned that bone marrow transplantation is very efficacious in the early stages of cerebral ALD. We use the same enrollment criteria as would be used for bone marrow transplantation. We used we treated children that were in the early stages of the disease that did not have a matched sibling donor for a bone marrow transplant, and but did have evidence of gadolinium enhancement. We looked at their major functional disabilities. We looked at their MRI progression, and importantly, because this was a first gene therapy trial, we were interested in safety and have been monitoring for insertional mutagenesis. How is ex vivo gene therapy performed? Just a brief diagram to illustrate this. Once a boy has a lesion with contrast enhancement, we see the boy, we harvest their bone marrow cells. After we mobilize them out of the bone marrow, we select out the CD34 positive cells, transduce them with a lentiviral vector, giving a healthy copy of the normal gene to these cells. And then after a brief amount of chemotherapy with busulfan and cyclophosphamide, we deliver the cells back, and we follow these patients for 2 years. This is exactly the same thing as happens in a bone marrow transplantation, with the difference that these are cells from the boys themselves. So we have here the advantage that they are not recognized as foreign. We don't get engraftment problems. We don't get graft versus host disease. So does this work? We see here that neurologic function usually stabilizes in the vast majority of these boys, as shown on the left. The higher the neurologic function score, the more the boys are affected. You can see that there was one boy who was already progressing very quickly at the time of enrollment and then sadly succumbed to disease progression. There were 2 other boys who had some contrast enhancement that reemerged, and they underwent a separate bone marrow transplantation and dropped out of the study. But the vast majority of the boys, and we've treated now more than 35 boys, they are neurologically stable. And this is in stark contrast to what we see in an untreated cohort, where usually the NFS scores increase and patients become more and more symptomatic. What happens to the imaging? You can see the usual MRI lesion in the splenium here in the back of the brain that stabilizes 1 year and 2 years after treatment. This is again very different from what you see in an untreated patient, in whom the lesion usually progresses into the subcortical regions here and spreads. Contrast enhancement usually goes away after treatment, here seen at 1 year and 2 years. Again, very different from the untreated condition, where usually a garland of contrast enhancement is seen. So we think this is a milestone for this disease, and it's also been shown in metachromatic leukodystrophy to work very well, and will hopefully there also give rise to first FDA-approved drug. We think there's encouraging efficacy data, and we're also reassured by the fact that we have not seen any clonal dominance in the side effects we see. However, we do take seriously those have to do with myeloablation, so the kind of chemotherapy that leads to immune suppression causes some transient infections and fevers. We have to monitor for that. But we're mostly concerned that some patients might go on to still develop spinal cord disease. As Dr. Fatemi mentioned, AMN is the axonopathy of the spinal cord that we see, and that might need a separate treatment modality. And here there's been very exciting developments in the field of gene therapy. Notably, Brian Casper and Jerry Mendel have treated patients with spinal muscular atrophy with AAV9 mediated gene therapy. Why is this of interest to us? Because in SMA, the target is the lower motor neuron that sits right here in the spinal cord, and right adjacent to that are the corticospinal tract and dorsal columns that are affected in AMN. So just the proximity alone gave us hope that this might also work for AMN. And so we packaged the human ABCD1 gene into an AAV9 vector, and this is work of Casey McGuire and Yi Gong in my lab, and they were able to show that delivering this in cell culture, they got right into the peroxisomal membrane with this construct, and were able to lower very long chain fatty acids in vitro in the dish, as well as then in vivo when they delivered into the brain, into the ventricles, or intravenously, they hit the cells that usually carry ABCD1. So we have a first proof of concept that has now led us to develop a more targeted approach using an intrathecal osmotic pump, where we are able to deliver AAV9 ABCD1 directly to the spinal cord, the area that is affected in adults with AMN. And we think that that not only increases spinal cord targeting, but also reduces leakage into the systemic circulation, where we probably don't need this gene delivery to go. So just to conclude here, that we've had first reassuring safety data and encouraging efficacy data in the first gene therapy trial for ALD, and this has also been shown by the group from Milan and others to happen in MLD as well. So we think there is some value to correcting the mononuclear phagocytic cells that come from the bone marrow and then go up into the brain, become microglia. But the timing of that intervention is critical. We've seen if we do that too late, it doesn't really work. We need to do it early when the inflammation is visible, but we need to do it before the lesion is too extensive. And I hope I've convinced you that it really matters what type of what phenotype you are targeting, even though you might carry the same gene defect. In one case, you might have brain disease, and that might require a different approach than spinal cord disease, as often is seen in adults. And targeting the right structures with the right gene therapy approach is critical. So in brain disease, microglial pathology is prominent, needs correction, can be corrected through bone marrow cells. For spinal cord, you likely need a different approach. And here the AVs, as in spinal muscular atrophy, have been very successful. But over time, we'll probably see a multimodal approach where different gene therapies might be combined, and the route and overall approach really make a difference. So just to end on a upbeat note, I think we've really seen that the power of genomic medicine has been transformed. I started my clinic, most of the boys came in wheelchairs, and you can see that here on the left. Many of the boys were really at death's door, but now many of the boys, as this boy who was the first one to undergo gene therapy, are leading full lives, very functional. This is a photo I got from the family showing him playing soccer last fall. So very gratifying to see this happen. Just to obviously acknowledge that it takes a village of people, and that we couldn't have done this without the many different collaborations that also Ali Fatemi mentioned, the community at large, and of course the many courageous families and patients that participated in these studies. Thank you.